Bismillahirrahmanirrahim. Assalamu alaikum and a very good morning to everyone. Welcome to the second day of Theveli International Conference 2026. I am Amnat Huda from School of Medicine and I'll be moderating this session. It is my pleasure to introduce today's keynote speaker, Dr. Hassan Shafiq. Dr. Hassan Shafiq is a senior consultant in internal medicine with over 30 years of clinical experience in the United States and the Maldives. He started his medical journey with MBBS from Tribhuvan University, Nepal, and MPH in clinical epidemiology from Johns Hopkins University, and an MD in internal medicine from Mount Sinai School of Medicine, New York University. His career has included appointments at the University of Minnesota Medical Center, University of California, Davis Medical Center, and St. Mary's Hospital, Arizona, where he specialized in hospital medicine, chronic disease management, and preventive care. Between 2015 and 2025, he maintained a private practice focused on preventive medicine, health screening, and healthy aging. He currently serves as a senior consultant in internal medicine at the Malay City Group of Hospitals, including Indira Gandhi Memorial Hospital, while also working as a visiting hospitalist in Northwest Medical Center, Arizona. His interests include preventive medicine, clinical epidemiology, cardiovascular risk reduction, healthcare quality improvement, and medical education. So today, Dr. Shafiq will be sharing insights on transforming preventive healthcare in the Maldives, a strategy for cancer screening and adult immunization. So now I would like to welcome Dr. Shafiq to the stage to deliver his keynote.
Thank you very much, everyone. Good morning, and distinguished delegates and respected faculty members, colleagues, and dear students. It is a great honor and privilege to be here in Maldives National University today. And I would like to sincerely thank the university to give me an opportunity in Maldives to discuss about the preventive medicine. Our healthcare system has made significant progress treating diseases rather than preventing it. However, I believe we now have an opportunity to place greater emphasis on preventing disease before it occurs, detecting disease at early stage, and keeping our population healthier for longer, as we have a disease population actually in par with Western countries compared to about 25 years ago when I left the United States actually. In primary healthcare, we often see patients only in hypertension, diabetes, CV, cardiovascular disease, kidney disease, and cancer, which already has been developed, rather than before we picking up them before they have the early signs of any disease. Could we have identified risk earlier? Could we have prevented the disease earlier? Could we have detected the stage of the cancer earlier? Will be our focus today. Preventative medicine gives us an opportunity to change the approach. Today, I'll focus particularly on three main important areas. First, strengthening the preventive service within the primary healthcare system. Second, implementing evidence-based cancer screening and early detection programs so that the cancers are identified at an earlier stage. And thirdly, including HPV vaccination, which is actually can cause cancer, and other vaccine appropriate for the population, mainly focused on elderly above 65. These interventions are not simply about adding more tests to the healthcare. They are about using the right test, right age, for the right age and for the right person, ensuring the abnormal results leading to a timely diagnosis and treatment. Maldives also has undergoing an important demographic transition. Our population is aging in par with actually in countries like Japan and Korea, where the population is already on the downward trend. The healthcare system we design today must prepare for the population for tomorrow, which we are going to discuss about it now. My goal today is not to suggest that every person needs to be screened. Rather, I want to discuss about the system evidence-based medicine model within the primary care system, how we can improve on this. I hope the presentation will stimulate a discussion about how we can move forward predominantly from a diagnosis and treatment-based model, which is doctor-focused, to a patient-based, rather preventative and early treatment model. Thank you very much again. I'm going to, let me begin the presentation regarding this strong emphasis on primary health care. So my main topic is actually transforming, as we don't have any primary care health system currently available for preventative services, rather is a doctor-focused than the patient-focused. So Maldives population currently in 2022 was about 547,000, but the population is going to get aged over the next several years. In 2025, 5%, last year it was 5% of the population was age 65. In 2031, we have become an aging population because the 7% of the population is above 65. By 2044, we will be an age society actually. That is about 20 years from now. And 52 will be a super age society, unfortunately, with the population, 1/5 of the population will be above 65. And this is the trend we are going currently. And WHO has studied multiple studies for NCDs, non-communicable disease, accounting 84% of all the death is related to this actually. It's a quite a high number actually. A study done in Farfatol, this is more like a pilot study. It shows 90% of the eligible population in Farfatol, selected population of Farfatol. They found out that 9% of the population was diabetic, 14% was hypertensive, and 22% had high cholesterol. This is actually done proactively by the WHO. Unfortunately, we don't have a system to do that at the moment. The Farfatol experience demonstrates a proactive population-based screening through primary care can identify substantial number of people previously undiagnosed, which are currently in the whole population. And the compliance rate was excellent according to them, according to the study. About 73 to 74% population were compliant with medications. So I'm going to focus more on cancer and a little bit about vaccination also. The cancer death in world population in 2020 was about 10 million. According to WHO studies that was done, which is actually related, I don't think the numbers are correct probably, because we are relating to the general population in the South Asia. We had around 496 new cancers. Among that, 264 were death. That were recorded in 2020. So almost 50% of them died because of the late diagnosis of the cancers actually. Now, increased need, so I'm going to focus on need to organize screening, expanding adult immunization, and long-term palliative care among the older population. So as I mentioned before, 2044 will reach 14%, which is considered as an age society. So common cancers increase is related to all these mentioned here. population is currently aging, increasing obesity, which is about 54%, almost 50% of the population currently. And there's a study done in University of Texas, MD Anderson, and American Cancer Society. The cancers from obesity is significant. And tobacco smoking, physical inactivity, which contribute to obesity again, dietary changes, and also long-term life expectancy, which is going to happen definitely in Maldives in next 20 years. So population aging actually increase. I'm sorry, doing some technical terms here. I hope everybody will understand. I had to put this in actually. That's why I'm talking about it. So population is aging because old age, the DNA flows cannot be repaired by immune system, and immune system is weak and risk cancer. Increase obesity, as I mentioned, 50 to 54% of the population are actually overweight or obese. And this can increase immune system chemicals, that is leukotrienes and stuff, chronic inflammatory, constant irritation that promotes abnormal cell division. The other thing is that when you have obesity, we have a high level of insulin in your body, and it also releases ILGF, that is insulin-like growth factor 1, which increases actually, increases the abnormal cell in your body. Fat cell produces hormone, which are not supposed to be produced, including estrogen, that can increase the chance of having breast cancer and uterine cancer. And the other thing is about the altered adipokines. These are the hormones that are produced on normal fat cells, and leptin, which is actually increases the cell growth, and the adipone activity decreases cell, which actually decreases the abnormal cells causing apoptosis. These also can be increased in the case of, this is decreased actually in the case of obese patient. And the population, the other cause that for cancer is actually tobacco smoking. There are 90,000 smokers in 2022. That's about 1/4 of the population are smokers. And their chance of having cancer for lung, mouth, including tongue, throat, and bladder cancers tobacco can cause this. And the other one is dietary changes. We are actually moving to a pretty healthy diet, actually, to a processed diet. Unfortunately, even children are obese because of this. And it has a high chance of having colorectal cancer, which has recently increased even in Western society. And the screening for colon cancer age has decreased from 50 years to 40 years now, 45 years actually. So these are the cancers usually found in Maldives. And according to the highest number of cancers are breast cancer, followed by colon cancer, lung cancer, cervical cancer, thyroid cancer, and liver cancer, and prostate cancer, and stomach cancer. Stomach cancer is actually an interesting thing. It is extremely common in South Asia and developing countries because there's a Helicobacter pylori infection. Is an infection that is chronic that can cause cancers of the stomach, which should have decreased in Maldives, but there was no study or anything available currently about this. So the information was taken from a study that was run WHO in 2024. So this is also related to the South Asian population. I don't think these numbers are actually correct, unfortunately. So we don't have a system to monitor this correctly because some patients go immediately outside for screening and treatment. They are not falling into our screening category here at the moment. So breast cancer were 80 to 100. Among that, 50 to 70% of them had late cancers, stage 3 and stage 4. The chance of death increases significantly on these patients. Colorectal, 55 to 70% were diagnosed with late stage 3 and stage 4. Lung cancer, about 85% were diagnosed with lung cancer in the late stages. And cervical cancer and the prostate cancer is the same, 60% around. And the stomach cancer, it is about 6 to 65%. And liver cancer, which is actually pretty bad here, unfortunately. We had a population of a lot of people with hepatitis B infection for several years. And now we are getting actually cancers of them and end-stage liver disease from that. And the thyroid cancer and ovarian cancer and some leukemias. So the mortality from cancer mortality is around 15 to 20% in people who had cancer within the population. The cancer responsible for highest mortality is actually lung cancer because of late diagnosis. Colorectal cancer, actually the colonoscopy is non-existent practically in Maldives, even though we have a large population with anemia. Most of them blame actually thalassemia as an anemia cause, but when I have been here actually for last 9 months, we did some testing on the blood. Most of them have iron deficiency anemia. That is probably from bleeding from probably an ulcer or cancer. But they live 10, 15, 20 years with this, and it could be avoided, you know. The other thing is the breast cancer and the death from breast cancer in advanced cancers. Breast cancer is interesting because the treatment mortalities are excellent right now. And the options of them living with the stage 4 cancer is pretty high without dying. So most of them are extremely advanced stage 4, spreading to the brain and spine mainly, and stomach cancer. Major challenges currently facing us are late diagnosis. Late diagnosis. This is the problem we are having currently. Most of the patients are diagnosed because they have some difficulty in breathing or weight loss or something like that. They come with stage 3 and stage 4 cancers. Breast cancer is 50 to 70%, as I mentioned, and we after screening, which I'm going to follow up next slides, it can be decreased from almost 70% to 20%. And the colorectal cancer can be decreased from 70% to 40%, and lung cancer from 85% to 50 to 60%. We can decrease these cancers because we can detect the cancer earlier. A reason for late diagnosis. So as I mentioned, there is no cancer screening program available, unfortunately, in the system. Low public health awareness, and also limited routine preventional health checkup, cultural stigma and fear. So I just want to bring this patient. So this young lady, she's around in her 60s from one of the islands, very innocent, wonderful lady. She showed up because she had lost around 10 kgs in a period of 6 months. So I was actually scared. I thought it would be cancer on this patient. For no reason, the patient lost weight. When I mentioned a little bit about that we need to screen for, check for mammogram and everything, she started crying. I asked her why she's crying, because nobody ever talked about cancer to me, and you're the one who is bringing up about cancer, and that was very painful for me, actually. I did the screening. The children who were with her actually accepted it, what I said, and we discussed. She didn't have cancer at all, and she was saying that, somebody should have talked to me about this earlier. I have been in pain for last 2 weeks because the CT scan took 2 weeks to get it done. So people go through this stigma because nobody's educating the population about this, especially in the remote islands. The other thing is the geographic barriers. As we mentioned, we are multiple island nation, delayed in referral to specialist services. This is a big barrier, actually. Even if you have a mass in the breast or some other cancer lesion somewhere else, getting through the system is difficult currently because there are no systems set up for that. And limited availability of diagnostic services in the remote areas. Current screening gaps. Breast cancer, we need to, there is no organized mammogram, getting mammograms done, or even self-assessment or doctor's examination done. Cervical cancer, colon cancer, fit test, and colonoscopy, as I said, is non-existent currently. Lung cancer screening, prostate cancer, which is pretty easy, actually, prostate cancer screening. We can check a PSA on everybody who comes once a year, which is also not regularly done because there are no systems set up for that, unfortunately. So if you diagnose early cancer, 90% survival. Colon cancer, 90% survival. This is excellent, actually. 5-year survival is excellent. Cervical cancer, highly preventable disease, vaccination in children, and also lung cancer screening, people who are smokers. And also stage 4 cancer has substantially low survival rate because of actually the treatment kills them most of the time. Because treatments are extremely, extremely painful and damages the other system of the body. So expanding primary care. So primary care system, here people think, even some of the doctors thinks that is mainly urgent care, treating patients with cough and everything like that. It's not that actually. It's screening for the cancers and everything, such as hypertension, diabetes. So we pick patients only when they come with the problem only. The introduction of HPV vaccination, which is actually a recent last 20 years, the infection of the cervical cancer and oral cancer, throat cancer has decreased significantly. And we have a system only to cover children between 10 to 15. But it usually starts, according to the guideline from CDC, is at 9 years through 45 years now. They have gone up. Strengthening primary healthcare prevention, development of national cancer registry, public awareness, referral pathway for rapid prognosis and rapid diagnosis, and increased access to diagnostic imaging. Most of the region, almost all the regional hospital actually has CT scans and MRIs and everything available, but it is not well utilized. I went to Pududufuri once. The machine was there with the cover on for almost 1 year. It was never used. So, because most of them are transferred here for testing. That is the issue here, actually. To Male, I mean, IGMH. Potential harm from excessive screening, false positive, unnecessary anxiety and additional testing, which I mentioned about the lady from Ireland who had it. False negative testing, we can miss the diagnosis. Overdiagnosis, sometimes we can have a lung cancer nodule, and if you don't monitor it, so some doctors not doctors, because the system is not available, we do biopsies on them and found out to be normal. And you can develop iatrogenic issues such as lung collapse and something similar to that. Overtreatment, and most importantly, psychological stresses. So we should educate the population that screening is nothing to be scared of. It is currently like what do you call, talking about is actually scaring the people out, because we never communicate with the patient about screening. And the cost goes significantly in stage 2 and stage 3 and stage 4 cancers. Targeting common high burden cancer patients, so the groups that can have cancers. So we should prioritize people who are higher risk of having cancers. This include cervical cancer, breast cancer, and colorectal cancer, and target the population with lung cancer that can develop lung cancer screening. So we should target population that are high risk initially, because we can convince more rather than just telling them to get the test done. This is the thing we should work on: screening asymptomatic individuals. So anybody who comes with age 50 plus, we should screen them at least for breast cancer, even 40 plus now, actually. There's an option of 45 and 40 plus. I'm going to come back to that again. So we should target them and convince them to get screening done. It's nothing to be scared of. So adopting international recommendations. So we have standards set up in Western countries already. We should follow those protocols and systems so that we can do the same thing, because our population is aging. Patients no longer die from diarrhea and simple TB and stuff like that. People die from, actually 80% die from non-communicable diseases such as cancer. Focus on high-risk patients, especially for chronic viral hepatitis, smokers, and hereditary cancers, families who have breast cancer. And ensure we can have access to the remote islands. All inhabited islands through regional hospitals, we can do a referral system, or even telemedicine, which is actually minimal currently to the islands, as we have 5G in every island practically. So we should be able to do that. And we are currently doing an opportunistic based screening. Only people who are showing up in the hospital, we are doing screening. Organize national and invitational recall or reminder. Now, what we can do is that we can establish a system, cancer registry, or there's a monitoring system, so that proactively the regional hospital or the general hospitals will be calling the patient rather than they're coming to us. This system has to be done. So once we do that, we can do yearly checkup on breast cancer screening or cervical cancer every 3 years. We can do screening, and patient will appreciate, and they will not be scared, because once you do it 2 times, everything is negative. They know that, I'm healthier. Early diagnosis and timely established standard pathway for abnormal results. And once you get the abnormal results, we should actually treat the patient with respect rather than calling them, oh, you have cancer, and come back. We should avoid that. We should bring them and treat accordingly, and build a educated system so that the junior doctors understands what they should be talking about. So public education. So we should have screening benefits and warning signs, particularly through social media and also from the TV and the radio, so that we can actually educate the population, actually practically bombard them with information, so that patients who are not hearing it hears it, so they won't be scared of doing the screening. We can establish a cancer registry, and we can follow up on that. And the burden on the economic burden will decrease significantly on us, and if we can catch up the cancers early, as I mentioned. Continuous monitoring. So when you have a population like in, say, Mafanno, we can have a regional primary healthcare, which we have set up already, urban healthcare. We can set up I'm actually involved in it right now. So I'm trying to set up actually, at least for a small area, so that we can do a pilot study on that. So that we can call, the nurses will be calling the patient, okay, this house has this patient, can you come? We have the option, you can do a free screening for breast cancer, or colon cancer, or these are the options. And once we get them into the system, we can call them every 3 years or every other year, proactively from the health system rather than patient coming. That's the most important thing we should do. We should proactively, once we start doing it, population will easily settle in for this, actually. So the screening for, I'm going to talk about a little bit about screening. I think this will be of help anybody around here. Cervical cancer screening usually start around at the age of 21. Usually we do pap smears at 21 every 3 years if it is negative, and also HPV testing. So in 16, and there are multiple human papilloma viruses, but we are screening for 16 and 18. And we can do those tests from the patient herself getting the sample here. The other thing is the breast cancer every 2 years, according to, but there are some American Cancer Society suggests that yearly checkup, annual and biannual fit test, instead of doing colonoscopy, which is more invasive, low dose CT scan. So people who are smoking right now, we should put into the system so that yearly checkup for CT scan, low dose CT scan yearly has to be done. People who have smoked 20 pack years, that is 20 pack a day for 20 years. And for the liver cancers we are getting right now, we should screen for alpha fetoprotein and ultrasound, which is a pretty straightforward test, simple test. Oral cancers, which is common here because of the betel use and the lime use and tobacco use, the only available test currently available is visual and oral examination. So let me talk about breast cancer. Normally screening start at 40. Start annual screening as per American Cancer Society, and shared decision should be made whether to do 40 to 45, but we expect them to do it 40. But USPSF, that's a US Preventive Task Force, they are recommending every 2 years. I will come to that, why they are doing 2 years, and ACS is doing yearly checkup. Now, the 2 year is because it aims to reduce the cumulative false positive cases, I mentioned. False diagnosis of cancer, which is actually not there. Unnecessary biopsies and anxiety. But the ACS is actually what I think is better, yearly checkup. So it gets the cancers fast moving cancers that are absolutely in earlier stages. So you practically do nothing to this patient except removing the lesion from there, and no chemotherapy, no radiation, nothing to be done on those patients. So yearly checkup is actually preferred according to, according to American Cancer Society. The other cancer that can avoid is cervical cancer and throat cancer, actually oral cancer. This is caused by the HPV virus, human papilloma virus 16 and 18 serotype. So we should start, as I mentioned, at age 21 through 29, and it's done every 3 years. And the HPV screening, which is actually cells taken from there looking for those two viruses, serotypes, start at 30 and done every 5 years through 65. Then colon cancer, normally, we don't, as I mentioned, non-existent, unfortunately, here. It's done every 10 years, starting at 50. But recently, because of the population in the West, started having younger people. I think one of the British crown princess also had the cancer recently, and they have lowered the screening to 40 to 45 because of the increasing. This is probably related to processed food eating, most likely. And the other group is people above 75, 76 plus. Now, these patients, if they are mentally good, physically good, and they have a healthy life going on, they need to be screened through 85. That's the new suggestion, stage C, as chart says. So the good news for the smokers is that after stopping smoking for 15 years, you'll be a non-smoker level risk of having cancer. So normally screening start at 50 to 80. So that is 20 pack year history, and they should quick. Less than 20 pack per year, no screening is recommended. But it's good to have a chest X-ray done at least on them yearly. Oral cancer, as I mentioned, is mainly visual examination. So actually the arachnid, everybody chew every day, and beetle, and the beetle quid, and also the Lyme is a group 1 carcinogen, actually. A lot of people are doing it right now. The chance of having cancer increased by 123 times, actually. We just talked about this. Yeah. So let me talk about some immunization. We have an actually exceptional childhood immunization program currently. But we don't have anything set up for adults. As I was working in this urban center here, it looks like that they have only people who are going to Umrah, that is pilgrimage to Mecca, and travelers and healthcare workers. And also during outbreak, we are giving a vaccination to these patients. So there's no system set up for that. For older people, not young. I mean, young they are doing pretty good. So most of the vaccines we are doing are this actually influenza, COVID, hepatitis B, which is important, HPV, which is important in the case, pneumococcal vaccine, and shingles. Now, the recommendation from CDC guideline is that vaccination for HPV, human papilloma virus, should be started at 9 to 14. Currently in Maldives is from 10 to 15. So 2 doses are given, and 15 to 26, 3 doses are given if you start at 15. But about 27, this is actually new. 27 to 45, this is practically new. 3 doses are given, but it's a shared decision with the patient and the doctor. So this another issue we are having. We should actually change our vaccination to PCV 15, 20, or 21. In the case of pneumococcal vaccination, this is for pneumonia prevention, actually. I just want to add this to this cancer thing, is that 1 dose should be given if you have pneumococcal vaccine 15, 20, or 21. So there are 4 types of vaccines, 10, 15, and 21. The last 3 are actually better. So 21 stands for there are 21 serotypes in it to prevent it, actually. I'm sorry, I'm using a lot of technical terms, but I cannot simplify that. So immunocompromised conditions, all these has to be vaccinated, including CKD and HIV and multiple solid tumor as well as blood cancers. So adult immunization, for this is actually practically new here. We have chickenpox, that is Fanabasandu here. There is a vaccine available. This is extremely disabling condition. People don't talk about it. If you have an oral infection of that, people can lose about half of their body weight because the infection, the post infection pain is so severe, it can linger for 6 months to 1 year. So this vaccine has to be introduced here. So implementation for the cancer screening, national protocols has to be established. Emergency EMR, electronic medical records, should be put a reminder so that the nurses and the system can call the patient instead of them coming back to us. Training medical staff and public awareness. The economic impact is actually huge if you pick up the cancer early. The cost for us will go down significantly because we are treating patients with stage 3 and stage 4. So reduce the treatment cost, fewer overseas referral, which is expensive, which has been actually exploited by some of the hospitals overseas. Fewer low chemotherapy exposure, and also radiation. So if you give radiation to the patient, they can have a real significant problem on their, for example, if you have a uterine cancer, give radiation, after 30 years, they'll have bleeding the rest of their life from the rectum. And in the case of lung cancer, if you do radiation, you can develop heart disease, because arteries can get clogged up. So those things can happen. Reduce hospital admissions because they will have less complication if you pick up early cancers. Reduce palliative care costs. So last 1 year of a patient before they die, that's the most expensive time they spend money on. So we can reduce this by doing palliative care consults if we know early diagnosis. And other thing is improving efficiency, as we discuss about calling the patients. So if you look at the us and the expenditure, if you stage 1, the survival is 90%, more than 90%. But in the stage 4, as you can see, is about 10 to 20 times relative cost, and the survival decreased by 30%, less than 30%. So from 90% to drop to 30% survival, and the cost goes up the other way, actually. So economic impact, again, more patients present with stage 2 without screening. Stage 3 and 4 is picked up rather than getting stage 1 and 2. Greater financial burden on us and the more cancers. So if you start screening, we want the cancers diagnosed at stage 1, actually. Curative treatments are more likely, curative, they will never have cancer again. Fewer hospitalization and complications, low overall expenditure per patient. Sorry. Yeah. Okay, I'm going to just go fast and finish. That's it, actually. Only 2 slides, so this is fine. Okay. Yeah. I'm actually done, I think we have been talking the same thing. Yeah. 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 Thank you. Yeah. Yeah.
It's very insightful as well as a thought-provoking presentation, and I'm sure the whole audience is waiting for more from you, but due to lack of time we are not able to give more time. But now the floor is open for your questions. If you have a question, please raise your hand. We will send a microphone to you, and please try to keep the question short so that more people can have the opportunity to ask the question.
Thank you for this very informative talk. I'm not a
Thank you,
medical
thank you.
doctor, but a
Yeah,
linguist, and
but
so
I tried my best to make it as
I could
simple as
follow you
possible.
perfectly. It was very insightful, and that's why, as a linguist, I'm thinking of your recommendations here also from a linguistic point of view. And I was wondering, what kind of language, or you call them also like educational campaigns, do you envision for reducing, for some people, the stigma of even approaching a doctor when they have symptoms of a disease or cancer that could be caught
So the
via
number
screening?
one thing we usually worry about is unexplained weight loss in a patient, you know. Unexplained weight loss is the number one thing we really worry about. Oh, somebody picking up when they do a examination, breast examination or something like that. Most of the cancers are diagnosed because the patient come with a problem related to the cancer. That is the problem here. So our job is to pick them up early. So instead of losing 10 kgs over 6 months, we can pick up when they lose 1 kg, you know. So the other thing is that smokers, they know about it. I saw boxes with the chest open with the lung cancer inside it. All the cigarette boxes that are sold here has this horrible looking pictures there in it, but still they smoke. And it's not, I don't blame them, they are addicted to it, but we have options for nicotine addiction actually. There are medications such as Chantix available. When I talked about this to the staff here, most of them are not aware of it because it's not available. But when I check it, it's available in India, but it was never marketed. I think this is more like a business thing rather than business and political. I don't know about political, but more like a business thing. They don't want to produce this because if everybody stops smoking here, we won't have heart disease significantly will drop, cancers will drop significantly, and peripheral vascular disease like stroke and heart attacks will go down significantly. And our job is to educate them, not to enforce that. And most of them will not stop smoking, you know. So that's the way. Any other question? Yeah. Is that enough? The question? Yeah.
Good morning.
Yeah.
I just want to understand, see, given the caregiving responsibility of women, they prioritize that first, then understanding the symptoms of cancer in themselves. The next thing is the financial autonomy and the access to services, even if they have a kind of, or after attending your session here, many of the women here could also go back and experience, okay, yes, I might have these symptoms, as the presenter has said.
Yes.
And even the financial autonomy and decision making, the social taboo.
Yes.
Three things
Yes.
that also stop a woman from going and accessing the health services.
Yes.
So being in the practice for so many years and having made this presentation, would you like to highlight upon the barriers faced in accessing the services of cancer in women?
Yes, it depends on the social status of the patient mostly. Some of them are not well educated or versed, but most of the population knows English now. That's excellent here. But the problem is that when we talk about cancer screening, if you put away that there is care in them, they will never talk about it. So accessing them should be done in the regional hospital or local, health centers actually. If we can get them, if we can set up a system so that we can start actually immunizing them from hearing this bad news, people will come forward much better. The other thing is that accessibility, as you mentioned, things are accessible in Maldives actually compared to like 25, 30 years ago. We have CT scan machines everywhere. I just told you about the machine was not even open, So those things are there, but no, some people are not using it. The providers are not using the system to find it because it was never set up from the government. They are doing their job, seeing the patient, taking care of their diseases. But when you put something preventative, it's pretty hard to put into the doctor's head who was trained 30 years ago, like me, So putting this system so that doctors get educated and the nurses get educated, and other healthcare providers such as even public health workers get educated on this, it will work here. It's a smaller population. We have 500,000. We should not be having stage 4 cancers actually, Yeah. Yeah. Mm-hmm. Yeah. 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 No, it doesn't exist. Yeah, yeah, yeah. Yes, 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 yes. I'm sure there are doctors who are working in American cancer. Sorry, Maldivian. I think I forgot the name of the doctor here.
Question.
There's Maldivian Cancer Society actually, and they are actually doing a lot of work on educating the population. But we should have a government-based education system, not from some private companies. They're trying their best, you know. So we don't have a system set up yet, you know, for cancer screening actually. Pap smears, I don't know. I'm not a GYN doctor. So, but other screening like mammograms and, you know, colon cancer screening, there's not set up or education system set up yet, to my knowledge. If I hope I'm wrong. You know?
Thank you, Dr. Shafiq,
Yeah,
for
yeah.
the elaborate answers. I think there is a question from this side. Yeah.
अस्सलाम वालेकुम आलगुन के नाम की आयशा धुसम मन कहेंगे तो मैं बाय डॉक्टर में विदाल वाइच साफ खुल्लम बेन मने हम डॉक्टर शफीक आले होंगे तो बाय बेफ्रम विदाल वाने में एम दोस्वी अवा में हूँ तंकल बॉर्डर दोस्वा में होंगे तो मिसाल का फस्तर्स अहर माथी के में हूँ MRI हेदीमा हेदम वाले रंगले नो हेदिया बड़ा घंटाने तो मैं कहता इधर कोस वगैरह दानेंगे तो दें कोलोन कैंसर वो समय को तशे
I have never heard of that in my life. It increases chance of dementia from having an MRI. Ingeta, me, midenui, andanatunga baligi humanu, nebiskakame. MRI is done like anybody who had a stroke. Most of them occurs above 60. And we do MRI all the time. Ingeta, there is no studies out. We talk scientifically, that not verbal. That there should be some evidence when you talk about it. I never heard of that. I might be ignorant, but I don't know. I don't think the MRI can cause dementia. Yeah. What was the other question? You said something else.
the colon cancer.
The colon cancer screening is so important. Processed food is increasing colon cancer significantly. There are genetic disorders. Colonoscopy is done every 10 years, which is every 10 years. This is 2 or 3 times the whole lifetime. So again, preventers we have polyping in the gym, we can remove the polyps, and we can actually treat the condition before it become a cancer actually. So I don't know who talked about it, but I'm not in agreement with that. No?
Okay, we have one final question.
I was curious how long you've been on the ground. You did mention the work at the urban center as well. I was curious to...
I just got it like a couple of weeks ago.
Okay. Since you did mention the civil society that's active on the ground as well, I was just curious from your perspective. I'm sure this is common knowledge among the practitioners or the academic people. And it's been there for a long time, but we still don't have the systems and structures entrenched locally.
No.
Why is that? What's the primary reason that drives that?
I don't want to blame people here, because we have gone from third world to first world very fast. Health-wise, the medical diseases are first world diseases. We don't have third world diseases here. No, I mean, people die from meningitis, from TB before. I have never seen a single case here admitted. When I was a MO, I was like 22 or 23 years old. We have patients lying down in the hospital with meningitis from TB, 3-4 patients. I mean, we don't get patients who are dying from diarrhea now. We don't get babies who are dying from dengue fever. The system is so good here. But what is missing is what I just talk about. There's no screening setup, which we need to do this. But nobody has done it yet. But we need to do it. This is all about the presentation, all about that actually. Okay. Yeah.
Okay, thank you very much, everyone. It's like we are really running out of time since there is another session also scheduled soon. Yeah. And Dr. Shafiq, in an excellent presentation. Again, thank you very much for your valuable insight. And also to the participants who showed keen interest in the session and asked many questions and making it more engaged. And I'm sure you have a lot more questions. Maybe you can talk to Dr. Shafiq outside after the session. Yeah. So now
Yeah,
I would
thank you very much. Okay.
Now I would like to invite our Vice Chancellor, Dr. Aishat Shahnaz Adam, to present token of appreciation to Dr. Shafiq in recognition of this excellent presentation.
Thank you.